Good day, everyone. I would like to present a case study that shows a collaboration between periodontics and orthodontics. This is presented by Group 6, Delmar, Gutierrez, Lopena, and Pineda. Here's an overview of what we will be discussing today. First will be the introduction, treatment planning, collaboration, procedures and techniques, results and outcomes, discussion, and lastly, the conclusion. Let's start with the patient's information. A 27-year-old female who has a chief complaint of a severe tooth mobility and discomfort of the maxillary incisor. The patient's history of present illness. She was referred by the periodontist for an orthodontic advice since her periodontal therapy failed to reduce tooth movement despite strict periodontal maintenance for half a year. The patient's medical and dental history was also recorded. So the patient has no history of any systemic illness. The patient's personal and family history were non-contributory, and based from her lab exam, her blood test results are all normal. Her physical exam shows that all her permanent teeth were present, and her oral hygiene was good, while the upper right central incisors showed class 3 mobility. These are the extraoral and intraoral photographs of the patient before the treatment. As you can see here, the area in the incisors of the patient has an edge-to-edge occlusal site and has an increased risk for a crossbite. This is her pre-treatment models, and we can clearly see that both sides shows angle class 1 molar connections, and a class 3 mobility was present in the central incisors in the upper right. This is the imaging exam, and it shows that less than 25% of the alveolar bone was remaining on the maxillary right central incisor region. You can see it through the periapical X-ray, and a mild bone resorption can be seen on the panoramic radiograph on the other regions. With the cephalometric analysis, it shows here on the table that the patient has a skeletal class 2 tendency and an average angle with proclined upper incisors and a retroclined lower incisors.
The treatment plan for this case was periodontal therapy and orthodontic treatment since the patient presented rotated maxillary central incisors, especially the upper right central incisor, which displayed class 3 mobility. The flow of the treatment plan for this periodontic orthodontic case was as follows. First is the initial periodontal treatment, which involves full mouth scaling and root planing, together with tooth brushing instruction. Then the periodontal surgery or the guided tissue regeneration. Third is the orthodontic treatment, and lastly is the supportive periodontal therapy. Periodontal therapy is usually done first in order for the teeth, specifically the mobile ones, to be healthy and stable enough to receive the next special treatment. The case started with the non-surgical periodontal therapy involving scaling and polishing to clean the teeth. Then, the surgical periodontal therapy, called the guided tissue regeneration, is done after, which aims to augment the bone as well as regenerate the periodontal tissues. This made it possible for the mobile teeth and the periodontal tissues to be in an acceptable condition. The next treatment is orthodontics. It was performed months after the periodontal surgery. The role of the orthodontist for this case is to correct the rotated maxillary incisors or the anterior crossbite by implementing an orthodontic mechanical control. After 5 months of active orthodontic treatment, the anterior crossbite was corrected, and at the end of the orthodontic treatment, the mobility of the upper right central incisor was improved to class 1. That concludes the first orthodontic treatment. However, when the patient was recalled after 15 months, there is presence of occlusal trauma and minor premature contact was still observed. So, they proceeded for the second orthodontic treatment for 3 months. During the follow-up checkup, occlusal trauma disappeared, and they established normal incisal guidance in the anterior region. The two specialists collaborated together to come up with a comprehensive plan with the help of diagnostic imaging tools. In the first stage, two treatment options were proposed: the orthodontic treatment or implant placement. The goal of orthodontic treatment is to establish a stable occlusion after periodontal treatment, which could benefit long-term periodontal health but also cause further destruction and be an economic burden. While the plan of placing an implant after extracting the mobile incisor, this could shorten the treatment time. However, there is a challenge to implant survival due to insufficient bone mass, soft tissue, and poor occlusal conditions. Periodontal and orthodontic considerations were integrated, which led them to mutually decide to treat periodontally hopeless teeth rather than extracting them. The interdisciplinary team chose the conservative option of conducting orthodontic correction because tooth mobility may improve following malocclusion correction. Before proceeding the treatment process, they established the patient's willingness and coordination to receive the treatment through the shared decision making with the patient. Since the periodontist and orthodontist were able to successfully assess and analyze the patient's condition and the treatment needed for the patient's case, they performed the treatment in a proper timing and sequencing. After the initial line of treatment, which was periodontal therapy, orthodontic intervention was done until the optimal result was met. In order to maintain a stable treatment outcome, ongoing communication and periodic evaluation were carried out by the two specialists. Through their collaborative efforts, the interdisciplinary team effectively strategized the best approach to achieving predictability of overall outcomes.
Procedures and techniques. A patient came to the dental office with a chief complaint of severe mobility and that she is having discomfort on her maxillary incisors. When the dentist checked her teeth, and by clinical examination and also with the aid of radiographic examinations, she was diagnosed with severe aggressive periodontitis. After the patient's visit with her dentist, she started her treatment for her periodontitis. A year and a half has passed since the patient started therapy. Despite strict periodontal maintenance, periodontal treatment didn't help in reducing the tooth mobility of the patient. The patient's dentist, which is a periodontist, then referred the patient to an orthodontist. The orthodontist took intraoral and extraoral photos before proceeding to treatment. Pre-treatment models has been made. History of past illness, personal and family history, physical examination, laboratory examinations, and imaging examinations were also taken. Based on the results of the intraoral and extraoral and pre-treatment models, it was shown that the patient have an edge-to-edge bite and there is a high tendency of crossbite in the anterior region, specifically in the incisors area. Class 1 malocclusion were observed on both sides of the patient's upper right central incisor and is classified under Class 3 mobility. The patient's history of past illness and personal and family history did not show any problems that can hinder treatment. The patient's physical examination was good. The patient have good oral hygiene and all of her permanent teeth are present. Laboratory results are all normal. In the imaging results using panoramic, periapical, and cephalometric radiograph, it was seen that in the maxillary region, especially in the incisors area or central incisor, severe bone loss is present. Thus, 25% of the alveolar bone remains. After the patient's assessment, the dentist performed periodontal surgery or guided tissue regeneration in order to strengthen the alveolar bone and soft tissue. During the procedure, significant bone loss up to the apical third was seen on both the buccal and lingual sides. A bone graft was performed in the area of the bony defect, following thorough curettage and debriding, and the bone fragments were subsequently coated with an absorbable collagen barrier to stop early epithelial cell adhesion to the root surface and create anatomical space for periodontal regeneration. Periodontal surgery process and periodontal status 3 months after surgery. As you can see in figure A and B, facial and palatal bone defects after flap elevation. C and D are the bone particulate transplantation and collagen membrane insertion. Figure E, operation after suturing, and figure F, an adequate state of periodontal health was seen after 2 months. However, after the resin splint was taken off, gingival recession was seen at the mesial and distal papilla, and the upper right central incisor still showed class 3 mobility. A straight wire appliance with a McLaren-Bennett prescription was placed. In order to straighten the teeth, nickel titanium arch wires were installed in the maxillary and mandibular arches, and a bioturbo was attached to the mandibular molars to reduce occlusal interference. After initial alignment, the upper right central incisors movement unexpectedly decreased to class 1 mobility. After 15 months, the patient was called back. Unexpectedly, despite the fixed retainer being stable and undamaged, a 1 mm gap was found between the upper right lateral incisor and the upper right central incisor, indicating the existence of occlusal trauma. Minor premature contacts was still being seen at this point. Second phase of orthodontic treatment and follow-up. 3 months were spent on the second orthodontic treatment. The gap between the canine and the premolar was first made by using a nitrile superelastic coil, and then it was finally moved to the distal side of the upper right canine. To improve the dark triangle and renovate the area, we used composite resin materials. To maintain the upper arch occlusion, a lingual bonded retainer from the canine to the incisor was inserted.
Results and outcomes. After periodontal therapy, strict control of periodontal inflammation was accomplished and bone regeneration was successfully performed. As a result, orthodontic treatment can be executed. It started with the application of archwire appliance to improve alignment of teeth, to reduce tooth mobility from class 3 to class 1, and to establish normal incisal guidance in the anterior region. As shown in the post-treatment cephalometric radiograph, there is no presence of occlusal interference, which was the reason of severe tooth mobility and occlusal trauma and inflammation. These post-treatment panoramic and apical radiographs show evidence of trabecular bone regeneration after 43 months after periodontal surgery and 2 months following the second orthodontic treatment. The patient's alveolar bone height was restored and has remained stable since then. The patient was instructed for a follow-up visit a year later. As presented in the extraoral and intraoral photographs, the patient's skeletal class 1 malocclusion and anterior crossbite was corrected, revealing a well-aligned, bilaterally balanced, and great improvement of occlusal contact between upper and lower dentition that provided better functional and aesthetic outcomes. Post-treatment follow-up visit involved periodontal probing of the maxillary central incisor to assess periodontal state of the dentition after 3 years post-treatment. Clinical and radiographic examination showed no looseness, no periodontal pockets, and no alveolar bone resorption, signifying that the patient is periodontally stable. The interdisciplinary treatment between periodontics and orthodontics was successful. The patient showed excellent signs of improvement after every post-treatment recall, indicating higher chances of treatment longevity and good prognosis as long as periodontium remains healthy. The patient was highly satisfied with the treatment results and outcomes because function was restored and appearance is aesthetically pleasing. Discussion. The patient had severe class 3 tooth mobility as a result of severe aggressive periodontitis with skeletal class 1 malocclusion and anterior crossbite. Clinical and radiographic examinations revealed that periodontal infection and occlusal trauma related inflammation led to advanced alveolar bone resorption. Once traumatic occlusal forces continually contacts poor periodontal tissues, bone loss is expected. With the aid of interdisciplinary approach, periodontal therapy and orthodontic treatment to a periodontally hopeless tooth is possible. After clinical and radiographic examinations, as well as diagnosis and treatment planning, it was necessary to perform periodontal therapy prior to orthodontic treatment. Periodontal surgery to reconstruct resorbed alveolar bone and restore soft tissues are provided by the guided tissue regeneration. Guided tissue regeneration is indicated during alveolar bone resorption to preserve and augment alveolar bone ridge and enable proliferation of cells and formation of bone. Guided tissue regeneration uses bioos graft material because of its osteoconductive properties that develop or regenerate bone. Collagen membranes are incorporated to increase regeneration process and ensure bone volume stability. Once periodontal treatment is successfully delivered, orthodontic treatment follows. Skeletal malocclusion is best managed with orthodontics because it helps correct alignment of teeth and maintain a balanced occlusion for proper function and aesthetic benefits. Clinical studies shows that orthodontically treated teeth may be at potential risk for inflammatory resorption, remodeling of periodontal ligament, and tooth displacement and mobility. High occlusal forces initiate inflammatory mediators that may induce inflammation and later root resorption and tooth loss. Therefore, orthodontic treatment associated condition should be properly assessed, diagnosed, and propose comprehensive treatment plan. This case report successfully treated skeletal class 1 anterior crossbite and tooth mobility orthodontically. The patient's periodontally hopeless teeth was carefully examined, diagnosed, and treated with the collaborative efforts of periodontist and orthodontist. Periodontics and orthodontics play a crucial role in both specialties because of the state of the periodontium determines the success of orthodontics. Support is the main concern of orthodontics because of potential complications in the future, such as periodontitis, root resorption, tooth mobility, pockets, and inflammation if not thoroughly evaluated. On the other hand, orthodontics can also induce periodontal inflammation once it experiences heavy occlusal load. Therefore, periodontists and orthodontists should communicate effectively to deliver a comprehensive and patient centered care. This case report presents an excellent interdisciplinary treatment because both periodontist and orthodontist diagnosed the condition precisely and planned the treatment accordingly in order to reach excellent treatment results and outcomes that will lead to good patient prognosis. This only proves that a periodontally hopeless tooth has hope through careful and comprehensive interdisciplinary treatment.
In conclusion, the loosened upper right central incisor was effectively retained in this case. The periodontal tissue remained stable during the follow-up period. These findings show that when periodontal inflammation is tightly managed, teeth with extreme mobility and bone loss can be salvaged with multidisciplinary treatment. Malocclusion related or occlusal trauma related tooth mobility should be taken into account when diagnosing and treating periodontal deficient teeth. Interdisciplinary treatment can save teeth with severe mobility and bone loss by controlling periodontal inflammation and addressing malocclusion associated or occlusal trauma related tooth mobility.